All right. Welcome back, everybody, to the Medical Biochemical Genetics Clinical Course Seminar Series. It's November 3rd, 2023, week 16 of the series. And we're happy to welcome back Dr. Reed Sutton from Baylor, who's going to be talking about neurometabolic disorders. This is the second in his series of lectures. A couple of housekeeping things. I'm posting right now the CME code in the chat. Both the link and the text works, so whichever one you want to use, feel free. Questions probably saved to the end. I'll keep watching the chat, but because of some logistical things, we're going to be tag teaming for advancing slides, so I might not see it. We'll see how that goes. Otherwise, this is going to be, as always, recorded and posted on the SIMD website, simd.org, probably, hopefully shortly after this. But thank you all for joining. I understand it's ASHG week, and so people are busy. So if you're joining from ASHG, like Dr. Sutton, or if you're at home, that's cool. Thank you so much for joining. So with that, Reed, I'm going to give it to you and try to follow your lead on changing slides here.
Thank you, Pete. First, I do want to apologize to Pete for all the issues I've caused with his lecture from moving the time. And then as he mentioned, the logistical issues are that I can't access my computer. So he's been being kind enough to run the slides for me. So he does a great job with this, and I apologize that I seem to be trying to do my very best to like muck things up. But we'll go ahead and get started. So on the next slide, you'll see the outline of the disorders that we're going to talk about today. We're going to go through a variety of these other neurometabolic conditions, including disorders of dopamine, serotonin, GABA, and succinate semialdehyde dehydrogenase. We'll talk about the disorders of serine deficiency, and then vitamin disorders that can result in neurometabolic phenotypes. Next slide. So the objectives of the talk today are that by the end of the talk, hopefully you'll be able to list the phenotypes and identify the biochemical findings that correspond to various disorders of neurotransmitter biosynthesis and recycling, to be able to describe therapeutic approaches for neurotransmitter disorders, describe the roles that serine plays in neurons and the consequences of deficiency, and to identify the signs and symptoms as well as laboratory biochemical patterns for various vitamin disorders. Next slide. So again, we'll start with the neurotransmitter disorders, dopamine, serotonin, and GABA, and SSADH. So the first one we'll talk about is aromatic amino acid decarboxylase deficiency. The clinical presentation of this disorder can range widely from the first few days after birth up into adulthood. The typical presentation is with low muscle tone, rigidity, similar to that seen in Parkinsonism. Oculogyric crisis, I've highlighted here in blue because this is a relatively unusual phenotypic or physical exam finding. And so there aren't a lot of conditions that would present with oculogyric crises. And so if you see that, AADC deficiency should be on the top of your differential. Epileptic encephalopathy, dystonia, autonomic dysfunction can occur. The biochemical findings on cerebrospinal fluid analysis are low levels of homovanillate and 5-hydroxyindole acetate, or HVA, and 5-HIAA. The prognosis overall, particularly for early infantile forms, is relatively poor. Individuals with the kind of milder or later onset forms may have some response to treatment with monoamine oxidase inhibitors, levodopa, carbidopa, or vitamin B6. This is just showing the pathway here where aromatic amino acid decarboxylase catalyzes the conversion from dopa to dopamine, as well as 5-hydroxytryptophan to serotonin. You see these downstream products, again shown in light blue, vanilla mandelic acid, homovanillic acid, and 5-hydroxyindoleacetic acid that are low, as are often dopamine and serotonin, given the block. We also have shown that there is a biomarker in plasma that can be seen, 3-methoxytyrosine, which is also known as 3-O-methyl-dopa. It's shown in the light salmon color at the top, and you can see that when you would have a block or deficiency of AADC, this would lead to a buildup of L-dopa, and then through this methyltransferase, the L-dopa is converted to 3-methoxytyrosine. And so again, this is just showing you the various biomarkers over on the right in the box and whisker plot, with the elevated 3-O-methyl-dopa and low levels of the downstream compounds of dopamine and vanilla mandelic acid. The next disorder that we'll talk about here in the dopamine pathway is tyrosine hydroxylase deficiency. This, again, is going to give you a symptom similar to what you see with Parkinson's disease, with the hyperkinetic rigid syndrome and dystonia. They can have developmental delay, intellectual disability, as well as an encephalopathy. Seizures are seen occasionally, but not typically a major phenotypic feature. They, again, similar to Parkinson's disease, can have tremor and chorea. This is the step right before AADC that you can see over on the right, where tyrosine hydroxylase converts tyrosine to L-dopa. And so similar to AADC deficiency, you see low levels of homovanillic acid. But again, because the tryptophan pathway is intact here, the 5-HIAA should be normal. And so one could also look at this ratio of homovanillic acid to 5-hydroxyindoleacetic acid to test for this disorder. This disorder does not have elevated 3-O-methyl-dopa, as is seen with AADC deficiency, because again, this is a block prior to the generation of L-dopa. Unfortunately, similar to AADC deficiency, overall, these individuals generally have a poor or insufficient response to levodopa-carbidopa. The next disorder, again, here we'll talk about, is GTP cyclohydrolase deficiency. This is also known as dopa-responsive dystonia. The onset of this disorder is typically about school age in early childhood. They, again, present most often with lower limb dystonia, and this is usually the first presenting symptom that they have. They have a generalized dystonia that will develop without treatment, that we'll discuss in a moment. Again, these Parkinsonism features of rigidity and bradykinesia. As with AADC deficiency, they can also have oculogyric crises. Notably for GTP cyclohydrolase deficiency, these symptoms are often diurnal, where after an individual rests and there's kind of building back up of neurotransmitters that will be better upon awakening. Without treatment, they will progress to develop intellectual disability. This is the first step in biopterin synthesis. And again, this can be diagnosed looking at CSF levels of biopterin and neopterin. This disorder, in contrast to AADC and tyrosine hydroxylase, generally does have a reasonably good response to levodopa. Next, we'll talk about two other monoamine disorders, dopamine beta hydroxylase and monoamine oxidase deficiency. dopamine beta hydroxylase typically prevents with severe orthostatic hypotension, as well as noradrenergic dysfunction. They typically do not have cognitive impairment because this enzyme is present not in the brain, but in postganglionic sympathetic neurons that results in an inability of these postganglionic neurons to convert dopamine to norepinephrine. And so these individuals will have low plasma levels of epinephrine and no norepinephrine. And the treatment is with dihydroxyphenylserine. I should say all of these disorders, unless I specify, should be assumed to be autosomal recessive. I realize I didn't put it on some of these slides, but I will call out when it's something different than autosomal recessive, as with monoamine oxidase deficiency, which is an X-linked disorder. They typically have mild intellectual disability and aggressive behavior. This is a defect in the breakdown of serotonin. And so again, this block leads to low levels of the biochemicals vanillamindylate, homovanillate, and 5-hydroxyindole acetate. And there is unfortunately no known treatment for monoamine oxidase deficiency. Another neurotransmitter disorder is GABA transaminase or gamma aminobutyric acid transaminase deficiency. This presents typically with an epileptic encephalopathy. They may have chorioathetosis and myoclonus. You may see delayed myelination and deep brain hyperintensities, as shown with the white arrows on the MRIs over on the right. These individuals have increased levels of GABA in CSF and plasma, and there is presently no known treatment for GABA transaminase deficiency. This is another biomarker shown here from plasma. I'd mentioned the kind of traditional way to diagnose this is with the CSF, but you see the pathway here over on the left with the red X showing the block from a deficiency of GABA transaminase that leads to elevated levels of GABA. But GABA can be spontaneously interconverted to another compound called 2-pyrrolidinone. And this compound can be measured in plasma. And so you see over on the right a box and whisker plot with the open circles being individuals without GABA transaminase. And you see these two filled red circles with levels of 2-pyrrolidinone that are 6 standard deviations above the mean for the reference population. And so this can be another biomarker as well in plasma, in addition to the elevated GABA levels in CSF. Succinate semialdehyde dehydrogenase deficiency is another disorder of GABA metabolism. These individuals present again with fairly nonspecific neurologic features such as developmental delay and intellectual disability, seizures, low muscle tone, and ataxia. They also similarly can have findings on brain MRI, similar again to what you see with GABA transaminase, including abnormal myelination, T1 hyperintensities, and cerebellar atrophy. This classically is diagnosed by finding elevated levels of gamma hydroxyisobutyrate and GABA. You see over on the right the pathway where we saw GABA transaminase on the previous slide that converts GABA to succinate semialdehyde. This is the step that follows that, where succinic semialdehyde dehydrogenase converts succinic semialdehyde to succinate that can be recycled to alpha oxyglutarate. And so in this disorder, again, you kind of get back up an increase in GABA, as well as increased levels of succinate semialdehyde. Next slide. So now to kind of summarize these different neurotransmitter disorders that we have reviewed, and to kind of highlight specific or non-specific findings. So overall, the GABA-related disorders, so GABA and succinate semialdehyde dehydrogenase deficiency, typically are non-specific epileptic encephalopathies that may have some brain MRI changes. The DOPA-related disorders typically present with features of Parkinsonism, such as dystonia and rigidity. That is a fairly unique finding, particularly in children. And within those DOPA-related disorders, both AADC and GTP cyclohydrolase deficiency have this relatively unique phenotype or uncommon phenotype of oculogyric crises that are associated with that. Also, again, among these DOPA-related disorders, being mindful that if there is a history of worsening function later in the day and improved function upon awakening or diurnal variation, that this would be more consistent with GTP cyclohydrolase deficiency. As I'd mentioned, that while there's not treatment available for all of these disorders, there is for some, such as GTP cyclohydrolase, and early diagnosis may be helpful in preventing further symptom development, such as intellectual disability. And again, unfortunately for these disorders, there's not any sort of finding that would be detected on either kind of routine clinical chemistry testing or even some of our standard biochemical testing like plasma amino acid analysis or CSF amino acid analysis. You really have to be considering these disorders and send the specific test in order to identify them. Next, we're going to talk about the serine deficiency disorders. So there are 3 enzymatic deficiencies and a transporter deficiency that can result in serine deficiency. There's phosphoglycerate dehydrogenase, phosphoserine aminotransferase, and phosphoserine phosphatase deficiencies. These are all autosomal recessive, as is the transporter disorder, and they lead to a broad phenotypic spectrum where that ranges anywhere from kind of the early infantile lethal form that can be associated with multiple congenital anomalies, as well as significant neurologic dysfunction. There's a moderate infantile form that presents with severe neurological manifestations and growth deficiency. And then there's a milder childhood onset form that's primarily intellectual disability. This is showing the pathway of de novo serine biosynthesis, where over on the left-hand side, whereby glucose is converted to phosphoglycerate. And you see these 3 enzymatic steps that I'd mentioned earlier: phosphoglycerate dehydrogenase, phosphoserine aminotransferase, and phosphoserine phosphatase that convert glucose into serine. Serine, of course, also can come from other sources, as shown in the bottom right, including diet, biosynthesis from glycine, endogenous protein turnover, and as well as phospholipid turnover. And we'll talk about phospholipids, I think, on the next slide. So here, over on the left, this is just kind of showing you the pathway that we looked at on the previous slide with the de novo biosynthesis of serine from glucose or from glycine. Serine is a neurotransmitter, and you see shown being excreted here from the astrocyte into the synaptic space, where it can serve as a neurotransmitter. But also you see over on the right, in addition to this neurotransmitter function, there are a variety of other functions, notably shown at the top, where serine is needed to synthesize various complex lipids, such as ceramides and sphingomyelins. Next slide. As I mentioned earlier, there's also this serine transport defect, and that's highlighted over on the left with the red box, where this transporter is important for moving serine out of the astrocyte over to the postsynaptic neuron and back. This again is a recessive disorder because mature neurons lack phosphoglycerate dehydrogenase, and because the blood-brain barrier is poorly permeable to serine. This becomes an essential process that we kind of can't just treat necessarily, but expect that diet's going to compensate. The neurons are dependent upon the supply of serine from astroglial cells, and the phenotype again is similar to what we see with the other serine biosynthesis disorders. So as I mentioned earlier, I'm not going to read everything on this slide, but I'm kind of providing it to you for your reference. I mentioned that again, the kind of infantile form, sometimes the eponym Neulaxova syndrome is used, again, has, in addition to neurologic issues, various birth defects and other physical examination findings, whereas again, the kind of later onset forms are primarily neurological, sometimes with other kind of minor anomalies like cataracts or reducted thumbs. And then again, the later onset enzymatic deficiencies, primarily neurologic without growth or issues or physical anomalies. And then the transporter disorder, again, you can see on the far right, again, similarly has primarily neurologic issues such as, again, developmental delay, intellectual disability, and seizures. They also can have microcephaly with the transport disorder. This is a table showing the relative levels of various biochemicals that are seen with the different age of onset of these disorders. You see that Neulaxova is rather rare, and so there's not a lot of data about the kind of typical ranges for CSF or plasma serine and glycine. You can see over in the middle and the far right columns that, again, the levels are typically going to correspond with the severity, or going to be what you might expect with the severity, with the infantile having lower levels of serine compared to the later onset overall, and also notably that the CSF serine, again, is typically going to be a much tighter range, since the CSF, the blood-brain, since serine can't cross the blood-brain barrier, and so you see that this is probably going to be a bit more sensitive for the diagnosis. And then, sorry, thank you, Pete. In the bottom, again, just kind of showing, and we'll talk more about it on a subsequent slide, that treatment can be with serine and or glycine, and that has been shown to probably result in some improvement in some of these neurologic features like epilepsy, spasticity, and behaviors. Next slide. This is just a case I will show of a 1.5-year-old male with intrauterine growth retardation, microcephaly, and global developmental delay. Also had ichthyosis and anemia, and there was a homozygous variant in the phosphoglycerate dehydrogenase gene that was classified as a variant of uncertain significance. This is showing the biochemical testing. You can see here in plasma, the plasma serine level is quite low, as is the plasma glycine, and similarly, really quite impressive low serine in the cerebrospinal fluid. As I mentioned on a previous slide, when we were talking about the important roles of serine, one of those is in generating these complex molecules. And I know it's kind of small, but if you'll see in the box and whisker plot over on the right, the top is showing serine. The second one down is showing glycine. And then all of the subsequent biochemicals listed there are glycerophosphocholines and glycerophosphorethanolamines, as well as sphingomyelins. We discussed earlier that serine is a substrate for 6 complex lipid and sphingomyelin biosynthesis. This is showing 4 individuals with either phosphoglycerate dehydrogenase or phosphoserine aminotransferase that initially presented with very low levels of serine. And you can see over on again, that box and whisker plot over on the right, the top one being serine, with the 4 colored circles representing these 4 individuals with serine deficiency disorders. And you can see all of them had serine levels 2 standard deviations or more below the mean. You see that the glycine level is also quite low. But what you also see there is that overall, these colored dots for the various glycerophosphocholines, glycerophosphorethanolamines, and sphingomyelins also show a trend to being on the lower end of the range. And this is just showing kind of that same data, but now before and after treatment. So these are the 4 patients, either at baseline or with serine treatment. And you see these dandelion plots where blue circles represent biochemicals that are 2 or more standard deviations below the mean. Red represent above the mean, more than 2 standard deviations. And the relative size and color of the circle is corresponding to exactly how high or low it is. So meaning if it's a blue circle, the bigger the circle is, the lower the z-score or standard deviation, and the smaller, the closer it is to normal. So what you can see, again, in a number of these individuals, that if you look at these aggregate dandelion plots of various glycerophosphocholines, glycerophosphorethanolamines, and sphingomyelins in respective order from left to right, that you see at baseline, many of these individuals have very low levels of these complex lipids. And after starting treatment with serine, you can see that there are many fewer big blue circles comparatively, showing that, again, it seems like the treatment with serine is improving the complex lipid biosynthesis. And subsequently, Carlos Ferreira and Hilary Vernon also showed this finding that elevations of alanine and low serine in these conditions lead to perturbed ratios of various sphingolipids that are contributing to the neurologic phenotype. So to summarize these serine disorders, serine synthesis and transport disorders cause various neurological phenotypes, and particularly at the severe end of the spectrum, can also be associated with multiple congenital anomalies. Cerebrospinal fluid levels of serine are probably the optimal diagnostic test, Although, again, if you do see low serine levels on plasma amino acid analysis, this should lead to suspicion and further evaluation for these serine deficiency disorders. Treatment with L-serine may prevent or at least ameliorate symptoms if started before they develop neurological symptoms. And I've shown that in looking at various complex lipids, glycerophosphocholines, ethanolamines, and sphingomyelins, that this could be a tool to assessing response to serine therapy or even other therapies that maybe would be developed in the future for these conditions. As I'd mentioned, certainly serine is a neurotransmitter, and so part of the phenotype may be related to just a generalized serine deficiency and lack of an important neurotransmitter, but also particularly, again, some of these non-neurologic phenotypes or the structural brain abnormalities certainly could also be the result of perturbed complex lipid biosynthesis. And then finally, we're going to talk about riboflavin, pyridoxine, and folate disorders. So we'll start with another case. This is a male who presented initially at 25 months of age. He, for a couple of months prior to that, had a possible episode of seizure, but had an EEG performed that was normal, and then also had an event of pallor and heart murmur, and was identified to have quite significant anemia and neutropenia to the point where he received 4 transfusions. Family history was of mixed race and ethnicity. They were non-consanguineous, and it was, other than some cancer, not really anything contributing. So on history and physical examination, the parents had reported that over the last couple of months that he had some developmental regression with refusing to walk and decreased use of words. There was a 3-day history of fever and cough, secondary to respiratory syncytial virus infection. On physical examination, he had nystagmus and ataxia, and brain imaging did not show anything other than some nasal congestion. MRI of the spine, however, did show T2 signal abnormality in the entire cord. And the considerations here were inherited bone marrow failure syndrome, such as Diamond-Blackfan anemia or ADA2 deficiency. Exome sequencing was performed, as happens frequently these days, and there was a single known pathogenic and a novel variant of uncertain significance in this gene, SLC52A2. And this causes a condition called Brown-Violetta-Van Laer syndrome type 2. Over on the left-hand column, you see the symptoms that are associated with this disorder of riboflavin transport that include things, again, mostly neurologic symptoms such as nystagmus and optic atrophy and muscle weakness, respiratory insufficiency. They can also have sensory neural hearing loss. And because of the important role that riboflavin plays as a cofactor for multiple acyl-CoA dehydrogenase deficiency and other disorders, you can have elevations of plasma acylcarnitines as well as urine organic acids. Over on the right column, you see the findings in this patient here corresponding to what was done. He had not had any biochemical testing prior to the exome results coming back. But if we go on to the next slide, I think, Well, not the next slide, I guess the next one after this, but on this slide, we're going to talk about riboflavin or vitamin B2. This is an essential vitamin, mainly comes from food as well as from our intestinal microbiome, which can synthesize riboflavin. It is a water-soluble vitamin, and so is not stored in the body, and any excess that we consume daily is excreted in the urine. The average requirement is about 1 milligram per kilogram per day. You can have a dietary or nutritional deficiency of riboflavin that causes chelosis, or kind of cracking of the corners of the mouth. You can also have sore mouth and sore throat, as well as hair loss, fatigue, vision problems, and anemia. There are 3 known disorders of riboflavin transport. There's SLC52A1 that's present in the placenta, intestine, and kidney. That is an autosomal dominant condition that leads to riboflavin deficiency. And then there are these 2 other solute carriers, 52A2 and 52A3. 52A2 is ubiquitous, including having the highest expression in the brain, and that's going to be important for the phenotypic differences that you see. And then again, the 52A3 solute carrier is again primarily in non-brain organs like intestine, stomach, and pancreas. So this is showing you a diagram over on the left of absorption of riboflavin from the small intestine to the bloodstream. And you see here that, again, there are these 2 genes that encode the 2 different transporters, with 52A3 encoding the transporter that gets it from the lumen of the intestine into the parietal cell and or intestinal epithelial cell, and then the 52A1 encoded transporter that gets it from the base of the parietal epithelial cell into the bloodstream. And then over on the right, you see solute carrier 52A2 that is highest expressed in brain, and it's important in getting the blood-brain barrier transport of riboflavin across to neurons, astrocytes, and other cells. So riboflavin is a cofactor for a whole lot of things, and I'm not going to necessarily read all these to you here, but it does have a lot of very important functions. And so the symptoms of this deficiency, whether again nutritional or due to inborn error of metabolism, can affect many different systems. So flavoenzymes, of which riboflavin is a cofactor for, typically catalyze 1 or 2 electron transfer reactions. There are hundreds of these enzymes that, again, as I mentioned, kind of are important in all sorts of energy metabolism, including kind of mitochondrial, respiratory chain transfer, and other things. And again, kind of these defects, as I mentioned earlier, because of particularly, again, the more notable thing with the multiple acyl-CoA dehydrogenase with riboflavin as a cofactor can lead to elevated plasma acylcarnitines. But again, some of these other things can also lead to dicarboxylic aciduria. And again, you can also have primary deficiency, again, as with multiple acyl-CoA dehydrogenase deficiency, that leads to inborn errors of metabolism, or again, kind of riboflavin deficiency that can lead to a secondary cause of these disorders. So treatment of riboflavin transporter deficiency for the patient that we talked about at the start of this section, it was initiated with riboflavin he was started on a very high dose of riboflavin at about 10 milligrams per kilogram per day, and advancing to 50 milligrams per kilogram per day monthly. Parents reported within a few weeks improvement of symptoms, and you can also see increases in various biomarkers in plasma, normalization of plasma acylcarnitine, and again, overall, particularly with kind of the slow and incremental advancing of the dose, this riboflavin therapy is overall pretty well tolerated. This is just showing, again, in this patient, the biochemical abnormalities, CSF in the left column, plasma in the middle column, and urine in the far right column, with the different kind of biochemicals that are seen. And again, as I mentioned, particularly if you note, again, because of multiple acyl-CoA dehydrogenase requiring riboflavin as a cofactor, one of the more notable things can be elevations of plasma acylcarnitines, but also, again, kind of organic acid, things like ethyl malonate or 2-hydroxyglutaric acid, again, from the various biochemical deficiencies. Next slide. So for this individual, 3 weeks post-treatment, the nystagmus had resolved. He was back to walking, although was still a little ataxic, and so was holding on to the parents' hands, pulling himself up and cruising along furniture. Parents felt like that his disposition had improved, and he also got a good response of anemia and neutropenia to the initiation of riboflavin. The next case is a 5-day-old with new onset seizures that responded to pyridoxine. DNA testing was sent and identified a homozygous intronic variant in the ALDH7A1 gene. Biochemical testing was also done and identified a low level of piperidine 6-carboxylate and a elevated level of piperacillate. So this is talking about succinic semialdehyde dehydrogenase deficiency. You can see that starting at the top with lysine, this lysine can be enzymatically converted to alpha keto aminocaproate, followed by piperidine 2-carboxylate, piperacillate, and piperidine 6-carboxylate, shown on the right, or over on the left, or over on the right. Lysine can be converted to saccharopine, to alpha aminoadipic semialdehyde, and then finally, the final step here, succinic semialdehyde dehydrogenase converts alpha aminoadipic semialdehyde to alpha aminoadipic acid. Also note kind of this arrow in the middle where there can be interconversion between alpha aminoadipic semialdehyde and piperidine 6-carboxylate. Treatment with this is with pyridoxine, 100 milligrams daily. Often, what physicians will elect to do is, if they are ill with a fever or other condition that may increase their risk of seizures, would increase the dose temporarily during that brief period. But because of the potential for high doses of pyridoxine to cause a sensory neuropathy, overall, it would be recommended not to exceed 300 milligrams daily, again, unless for a short period of increased seizure risk. A lysine-restricted diet can also be helpful, and arginine supplementation can be used because arginine will compete for the diabasic amino acid transporter and competitively inhibit lysine, which again will lower levels of piperidine 6-carboxylate. Next slide. And then another case to represent, I think, another of these disorders. This is a 5-month-old who had new onset seizures and hypernatremic dehydration. He had been having chronic diarrhea that was attributed to a course of amoxicillin that he got for an upper respiratory infection. He was also irritable and had pancytopenia. He had elevated level of totoplasma homocysteine, but normal levels of vitamin B12. Bone marrow biopsy was performed and showed pancytopenia with megaloblastic changes. He went on to progress to respiratory distress. Notably, on family history, there was a brother who was born outside of the United States who died at 11 months of age with anemia and respiratory distress. So he had both rapid exome sequencing and blood testing of vitamin B6. You see that the vitamin B6 level is slightly below the normal range, and the rapid exome identified a homozygous variant in the solute carrier 46A1. So he was started on leucovorin, 10 milligrams IM daily, with follow-up now at 5 years, has normal growth, no seizures, normal development, and normalization of his CBC. So this is a case of hereditary folate malabsorption. So you can see there are two disorders of folate. One is involving an intestinal transporter, shown in the middle column, one a cerebral folate transporter. You see that for hereditary folate malabsorption, because this is what is getting folate into the bloodstream, in addition to the neurologic presentation of regression and seizures, you're also going to have hematologic manifestations, including megaloblastic anemia and poor growth and diarrhea. In contrast, cerebral folate deficiency, again, because the intestinal absorption is normal, but it's the transport across the blood-brain barrier that is impaired. This is primarily a neurologic phenotype, including spastic paraplegia, ataxia, dyskinesia, and intellectual disability, but is lacking the systemic manifestations, including, again, lacking hematologic or growth abnormalities. In both conditions, cerebrospinal fluid levels of folate are normal. However, in cerebral folate deficiency, the blood level of folate is normal because, again, the intestinal transporter is working. However, in hereditary folate malabsorption, again, because you're not getting it into the bloodstream, the folate is low, not only in CSF, but also in blood. And then the therapy for hereditary folate malabsorption is either enteral or parenteral high-dose folate. For cerebral folate deficiency, in order to get it across the blood-brain barrier without the folate transporter, the therapy is with folinic acid. So to summarize these vitamin disorders, so we talked about riboflavin transport disorders that can lead to anemia and pancytopenia, as well as general and focalized neurologic symptoms such as nystagmus and ataxia. We talked about pyridoxine responsive seizures, where treatment is with vitamin B6, as well as lysine restriction and arginine supplementation, although noting that you shouldn't overdo it with pyridoxine because high levels can cause sensory neuropathy, but again, some individuals would do higher dose treatment at increased times of risk, such as fever or illness. And then finally, we discussed the two different folate transporter disorders, the hereditary folate malabsorption, which is a deficiency of the transporter that gets folate from the intestine into the bloodstream, that presents with both neurologic symptoms as well as megaloblastic anemia. And then cerebral folate deficiency. So this is the blood-brain barrier folate transporter, where intestinal transport works. It's just getting into the blood-brain barrier that does not. And so they present primarily with the neurologic phenotypes of spasticity, dyskinesia, and ataxia. And again, the treatment differences where for the intestinal transporter, it's with intral or parenteral folate. And then again, in order to get the folate into the CSF or across the blood-brain barrier without the functioning transporter, you need to use folinic acid. So I'd like to thank everyone for their attention, and Pete for his assistance, and I'm happy to take any questions.
There was one that came through the chat when you were talking about riboflavin transport from Dalen Richards. She was wondering if the route of riboflavin supplementation changed per type, particularly with 52A2 versus A1 and A3.
Yeah, these are ultra rare disorders. So I think you could just kind of try to do like a super high dose orally to try to see, again, particularly if it's like a missense variant or a splice variant, if you could get some across, or again, you could use a parenteral riboflavin.
We have one patient with it here, and you have to give it daily, so parenteral might be tough, but we have her on super high doses, 75 to 80 milligrams per kilogram per day. She tolerated it really well and went from hearing loss to a lot less hearing loss, and couldn't lift her arms above her shoulders to being mobile and agile and strong. So it's a pretty remarkable change.
Yeah, that's what we've used. We've used, again, like you said, just typically tried to use like high dose, like really high dose riboflavin, and hope that some gets in, not the transporter.
Yeah, we were worried about intestinal tolerance, but she did well with it. We just went up gradually, like you said.
Mm-hmm. Mm-hmm.
We have another one in the chat. Can you comment on value of serine, CSF, and plasma ratio for biochemical testing, specifically for the serine biosynthesis disorders?
Yeah, that's a good question. I don't know that anyone has published a ratio for serine deficiency disorders like we often will use for glycine encephalopathy. I would concede maybe someone has, and I'm unaware of that. I'm happy to be corrected, but I don't know that anybody has tried to publish that. One of the reasons we use it, and again, Pete's an expert glycine encephalopathy place, so if he wants to chime in too. But I mean, the reason, in my experience, in my many years of like signing out biochemical reports, I don't recall ever seeing anybody, at least particularly with kind of the classic neonatal onset glycine encephalopathy. Everybody usually always has pretty high levels of both blood and CSF glycine. And I think the reason we often will kind of do or harp on the ratio is because, either kind of diet can certainly potentially increase the plasma glycine level if somebody's on some, funny infant formula, or again, if there's blood contamination of the CSF, that you could potentially get elevated glycene. And so I think we use that ratio with glycine in CSF and plasma for glycine encephalopathy because of the worry, like, are these other things that are kind of confounding the diagnosis and finding high levels for serine deficiency disorders. I mean, there shouldn't really be a lot that gives you particularly isolated low levels of serine artifactually. And so I think if all the other essential amino acids are looking pretty normal and the serine is quite low, again, particularly in the CSF, that I'm not sure how useful a ratio would be for diagnosis.
Yeah, for glycine encephalopathy, usually the plasma is elevated, but the gold standard is the CSF, but the ratio helps distinguish the classic from the variant forms, lipoic acid synthesis defects, and
Right.
iron sulfur cluster defects. There's another question coming through the chat. Do you know if an accredited European lab that measures sphingomyelins for monitoring PSAT?
Not in Europe, no.
And for here in the States, you guys check it through metabolomics and plasma?
Correct. Yeah. So the data I was showing, I guess maybe I should have been a little clearer. Thank you, Pete. The data I was showing for those complex lipids, the glycerophosphorethanolamines, glycerophosphocholine, and sphingomyelins, that was from a plasma metabolomic analysis that had been sent to us from this collaborator in the Middle East.
And are you running CSF still, or is that for a while? I know you weren't.
We're on hold for CSF because we're having to redo our standard, which is, but I would say that we don't, there aren't like, there's certain, as far as like a screen, like from a screening standpoint, like for most all of the things I showed, they were pretty much all plasma, and we don't, like we often for these disorders I talked about where I was showing the metabolomics, like it's usually reasonably reasonably clear in plasma. It's maybe again obviously kind of from a research perspective or those sorts of things like CSF would be better, but it's obviously harder to get.
So keep Baylor metabolomics in mind if you're stumped or you want more details about things you might not be able to get from a standard amino acid analysis in plasma. Another question coming through the chat from Dr. Richards. For the serine disorders, if parents know their carriers, with maternal serine supplementation throughout pregnancy help some of the IUGR, microcephaly, fetal defects? And how often should we be testing severe IUGR for inborn errors via CSF analysis?
So that for the first part of the question, as far as I know, nobody has ever tried to treat like mother if there's like a known like severe serine deficiency disorder to see if some of those again congenital anomalies you see with new laxova would do it. My bet is that you'd have to have like pre-pregnancy, even if it were to work, you'd have to have pre-pregnancy testing, carrier testing on the parents to like kind of like we do with almost like maternal PKU or congenital adrenal hyperplasia due to 21 hydroxylase deficiency. You probably have to know they're pregnant within the first kind of month or so if you were going to have any impact, because again a lot of these congenital anomalies that you see with new laxoma or they're going to these malformations are embryologically going to be occurring in the first few months of pregnancy, right? That I think you wouldn't, but again I don't know that anybody has published that, and I would presume serine crosses the placenta fine, but again it may not, given that they've got these birth defects despite presumably moms having fairly normal presumably serine levels, and so again I don't know if it would even kind of get across the placenta. As far as the second part of the question, well, that's a loaded question because you're asking a biochemical geneticist. I do think I do agree with what I think the implication of the question is, in that certainly if you see somebody with multiple congenital anomalies, because of frequency, chromosome abnormalities should probably be at the top of your list, right? But I do think we shouldn't forget all of the various inborn errors of metabolism that can give you congenital anomalies. So again, obviously today we talked about the serine deficiency disorders. A couple of weeks ago, we talked about pyrimidine disorders that again kind of will mimic methotrexate embryopathy. Obviously there's Smith-Lemli-Opitz syndrome and a variety of other biochemical disorders that can give you congenital anomalies.
So she also, so there's a little bit more of the question that I didn't read. So she makes a very good point that low levels of things like serine are typically harder to detect than high levels of things that we might be testing for. So is it helpful to get amino acids, let's say, in a newborn who's IUGR and microcephalic and expect to be able to screen for something like this, versus getting CSF, I guess?
Yeah, I think that, that's one of the, I think the short answer is yes, the CSF is probably ideal. And that's kind of what I was trying to deliver as the take home message on that slide that had the table of the kind of the three columns with the kind of severe childhood onset and later onset forms, and showing the CSF plasma and serine levels that overall they are low. But again, I think to emphasize, they're obviously lower in CSF, and B, you don't have this confounding issue of like diet or other things that could potentially kind of you would have with plasma, right? And so I do think CSF would be the preferred sample, if you're really trying to screen.
I have a feeling though, if we're relying on biomarkers like that, we could have missed things in the past, but with whole exome sequencing, we probably under ascertained them before, and now we're picking up cases better because of molecular, and then maybe able to validate based on biochemical.
Agreed. Yeah. And I would also be a big proponent, since Pete has brought this up. I think increasingly people think exome is the end all be all, right? And the reason that for including some of these cases today is showing that you often wind up with these situations like I think the brown violetta band layer and some of the others where you've got a VUS, and it's a pretty non-specific phenotype, and you really need to advocate for Pete and I keeping our jobs. You really need the biochemical people to do the biochemical testing as a functional analysis to assess pathogenicity of these variants of uncertain significance.
Yeah,
because again, a lot of them are associated with treatment. So you don't want to miss treatment, but also you don't want to be treating somebody if that's not really what they've got, right?
yeah. Dalen's in the NICU now, so she's seeing a lot of LPs done on sick IUGR babies. It's a good point. And I imagine if you have a kiddo with IUGR and microcephaly, well, they're going to have microcephaly anyway because they're small. But IUGR and neurologic symptoms, Tim would definitely not mind running some amino acids from CSF if you can pull them off. Great questions. Any more for Dr. Sutton? Ooh, nice. There's a good comment in the chat for placental amino acid transport. It's an article talking about that. They're probably transported variably depending on which amino acids they are, but I'm sure serine gets transported. It's probably just a matter of how efficiently and how much you can give mom that actually gets over to the baby side.
Yeah.
They're regulated too.
And I also don't know if anybody has really looked at carrier parents to see if their serine levels are indeed entirely normal or not. It may well be, but again, I think we see, for example, with primary carnitine deficiency, individuals with carriers for carnitine uptake deficiency have levels of plasma carnitines that are kind of between the normal population and affected individuals. So
Wonderful. Any other questions for Dr. Sutton? But I just love these conditions. They're so rare, and it's great to hear about them because we typically get to hear about them once a year when you talk about them. So and keeping aware that they're out there and that we can not only find them and treat them, but treat them, that's very important. And having them on the back of our mind or maybe on the front, depending on what center you're at, it's a good thing. So
absolutely.
All right, folks. Well, thank you for joining later than usual. Really appreciate it. Next week is Dr. Larson from our center here in Colorado talking about mitochondrial disorders. It's the second in that series. And it'll be the same time as usual, not the advanced time this week. So thank you all for joining. Dr. Sutton, thank you so much for joining from ASHG and for being flexible. And yeah, we really appreciate it. Thank you. Thanks, guys. Have a good weekend. Bye.
Bye-bye. Thanks, Pete.